people start getting logged in. It's just barely noon now. But if you have, as people are getting logged in, if you have questions, go ahead and put them in the messages at the bottom of the screen. I do have a number of questions that you all sent me via email and via DM, and I will definitely um, be addressing those. But I also just wanted to give people an opportunity to answer question or ask questions right here in the live as well. Looks like people are just getting logged in. We'll give things just a minute to give people an opportunity, and then we will go ahead and get started. We have a bunch of interesting and a couple of fun questions to tackle today. So I'm going to give people just another second to get logged in, and then we'll get started. While people are getting logged in, I'm just going to take a moment and introduce myself. I am Dr. Jillian Goddard. I'm an endocrinologist and the author of the Substack Hot Flash, which is all about women's hormonal health. And I'll be answering some questions today, some of which I received earlier, and any questions that people want to put in the messages below. So without further ado, I'm going to go ahead and begin. The first question I'm going to answer today, I'm going to answer because I have gotten a version of this question from so very many of you in the last several weeks. And so I think it will be resonant with many of you. And that is sort of the timing of starting hormone replacement therapy. And I just want to start with a little bit of a conversation about why I think it is so confusing to people to understand um, sort of when they should be thinking about starting hormone therapy, and that is sort of twofold. On the one hand, I think a lot of people have heard the message that that one of the keys with hormone therapy is to start within a certain window of having your last menstrual period. That comes out of the Women's Health Initiative data. One of the things that we learned from that study is starting hormone therapy many years after your last menstrual period, more than 10 years after your last menstrual period, is at that point, the risks probably do not outweigh the benefits. So you want to make sure you're starting it early enough. But then there's also this sense that maybe you can start it too early, or that um, you have to be in menopause to start hormone therapy. And so I just wanted to clear up some myths and some ideas around that, because I think a lot of you have questions about it, and you're just not sure. Um, so I what I would say is the number one reason to start hormone therapy has nothing to do with exactly where you are relative to your last menstrual period. The number one reason to start hormone therapy is because you're having symptoms. Um, the most common symptoms, of course, are hot flushes and night sweats, and those are the things that hormone therapy is best studied for treating. But 80% of women have hot flushes and night sweats over the course of the menopausal transition. Most of those symptoms seem to occur in the 1 to 2 years before your last menstrual period and in the 1 to 3 years after your last menstrual period. And so, if 80% of women are having symptoms, that means that there's a huge number of women that we're not, that we haven't been treating their symptoms, because only about 5% of women use hormone were using hormone therapy between the years 1999 and 2020. So there's still plenty of people who could benefit from hormone therapy. So, but that is the number one reason to start hormone therapy is because you're having symptoms. I think where some of the confusion comes in as well is that there is this idea that when we're talking about treating perimenopausal symptoms, that we have to be talking about traditional hormone therapy that has come to be kind of, an estrogen patch plus a progesterone pill. And so people get a little confused about this formulation question because that formula is not often what's recommended when women are still having regular periods. And so if you're still having fairly regular periods, if you're still having a period, every 60 days or more, an estrogen patch plus progesterone might treat your symptoms, but it can lead to a lot of breakthrough bleeding. And so, a lot of times when women are still having fairly regular periods or they're still having fairly frequent periods, even if those periods aren't regular, we'll recommend a birth control pill instead. And I think people get confused about whether that counts as hormone therapy. But given the fact that the goal is treating our symptoms, if that birth control pill is giving you a nice, even dose of estrogen and progesterone, hopefully it's reducing or even getting rid of your symptoms. And so in that case, we would be using it as hormone therapy. If you have symptoms when your periods are less regular, so if you don't start having symptoms until you're only having a few periods a year, or even after you have had your last menstrual period, then sort of the patch plus progesterone can be a great way to go. Um, as far as starting it too early, I think, like I said, if you're having symptoms, it may just be more of a question of formulation and not so much of a question of starting it too early. Starting it too late, that window is pretty clear. We want to start within 10 years of your last menstrual period or by age 60. And so, really, while people have a sense that there's like this narrow little window that is the right time to start hormone therapy, that window that I just mentioned is quite vast. Women can start having symptoms often in their mid 40s, and so the window for starting hormone therapy may be 15 years or more. And so really there's not this single right time. The right time is when you have symptoms that need to be managed. And I would encourage anyone who is having symptoms that are disrupting their life to that they would have that conversation with their doctor and hopefully get some relief from those symptoms. And so hopefully that clears things up for people. If people have clarifying questions about that, definitely let me know either now and we can do some clarification, or you can always send me an email or a DM asking clarifying questions as well. Um, yeah. So again, hopefully that clears things up because so many of you have had that question recently. Um, Moving on, somebody sent me a really fun question. I thought this was a fun question for me to think about the answer to, and so I thought I would share it with you. And their question was, you know, I will often talk about there being a lack of data around um, supplements. And I think as women in midlife, we get targeted for ads for supplements constantly. I don't know. Maybe my algorithm is different from your algorithm, but I get constantly barraged with ads for different supplements. It seems like, everybody's selling something that's supposed to help me. And so the question was, what supplements, if any, do I take on a regular basis and why? And so I thought this was really kind of fun and interesting. So I will share. Um, The first supplement I started taking with regularity was actually magnesium. And I take magnesium glycinate at bedtime. Magnesium can make you sleepy, and so bedtime is a great time to take it. Take it in tablets. The reason I take it is because I get hormonal headaches and migraines, and there is good data to show that magnesium supplementation can reduce the frequency of migraine headache. And so that is why I started taking that. Um, the data around magnesium and sleep is a little less clear, but there may be some sleep benefits, and some people do feel like magnesium supplements definitely make them feel sleepy. And if that's the case, certainly it may be helpful for that as well. But I mostly take it for headache to prevent headaches. I take B12. I take B12 because I have B12 deficiency. B12 deficiency is very common in a couple of different groups of people. I personally have Hashimoto's, and B12 deficiency is really common in people with thyroid problems. And in fact, in my patients, I proactively check B12 if they have a known thyroid problem. B12 deficiency is more common in vegetarians. I'm not a vegetarian, but if you are, it would be worth having your B12 checked. And I see B12 deficiency a lot when people are complaining about hair loss. And so if you are experiencing, there's sort of a few different symptoms where I try to check people's B12s. Hair loss and unexplained brain fog are also can be related to B12 deficiency, and it's just so easy to fix. I take a little red um, melt under your tongue tablet every day, and that is why I take that. And then I've added a couple of things recently where I will be quite honest, the data is less clear, mostly because we just don't have a lot of it. But I started using collagen powder, which there is some data, particularly for collagen powder around um, skin and being a little bit vain. I thought that why not? It's not a complete protein, but it does add a little bit of protein to your routine. And I also um it is supposed to be helpful for gut health, particularly in runners. And while I am very much a slow recreational runner, I am not a competitive runner. I figured, why not? And like I said, it does add a little bit of protein to the routine. And then the thing I've been trying to add recently and have been failing at miserably because I just keep forgetting to do it is actually creatine. And I started thinking about that because there was a study recently that I wrote about. There was a Q&A maybe a month, 6 weeks ago about creatine and about specifically for women in midlife. So we had lots of data in the past on creatine, both in athletes, and I would not necessarily consider myself an athlete, at least not at this juncture, but also in elderly people, mostly in people over 65, 70, and in some cases, some studies were only in people over 80. So I definitely don't fit into that demographic. And so I had never really added creatine. But earlier this year, a study came out looking specifically at women in midlife and the benefits of creatine for women in midlife. And so the benefits were related to muscle recovery and uh, and energy and sort of feeling more energetic, more well rested. The The challenge is that the study that they did in women in midlife, they did not use the typical type of creatinine. They did not use creatinine monohydrate. They used creatinine hydrochloride. They did that for a couple of reasons. Creatinine monohydrate is associated with some gastrointestinal symptoms and with some water retention, especially when you first start using it. And so, since the studies used very specific doses of creatinine hydrochloride, I figured let's use the creatinine that they actually used in the studies. And one of the challenges there is it tastes terrible. Um, and so it's been hard to motivate myself to use it and to remember to use it because it it tastes, not surprisingly, very acidic. It tastes like the coating that is on the outside of like sour candy, but without the sugar. They make many flavored ones, but they tend to be very high in sugar. And so I have been trying to get myself to use this one that is not. So those are the only supplements I take. So like I said, B12 because I'm B12 deficient, magnesium because I have headaches and gets rid of headaches, collagen because there's maybe some wishy-washy data about skin elasticity and maybe about some gastrointestinal benefits. And I figure it's a little extra protein. And I'm trying to get myself to use some creatine based on the recent studies of creatine for women in midlife. Other things that other women sometimes need that you may need that I don't personally need, iron is a big one, especially if you're having heavy periods and you're iron deficient. You don't want to just take iron. You want to know that you're deficient because you can actually, iron is one of the supplements you can actually take too much of. Um, and I eat a fairly high dairy and fairly high calcium diet. But if you don't, you may want to think about adding just a little bit of calcium, especially if you're perimenopausal or menopausal, because it is helpful for bone health. In general, people need a total of 1,200 milligrams of calcium a day. To maintain healthy bones. And most people get about 600 milligrams in their diet. And so something in the neighborhood of 5 to 600 milligrams of added calcium can be helpful if your diet is typical and doesn't include a full 1,200 milligrams of calcium a day. But other than that, there's really no data that says that any of these other supplements are particularly beneficial. Um, Most of them probably aren't hurting you. The question is, are they really helping you? And I would say, as far as I'm concerned, it's not. It's not always. There's not a lot of data to say that it is. Um, I wanted to shift gears a little bit here, but first, let me just reintroduce myself. We've had a number of people join us. I am Dr. Jillian Goddard. I'm an endocrinologist and the author of the newsletter Hot Flash. And today we're doing an Ask Me Anything. I did get a number of questions earlier. Many of you emailed me and DM'd me. But if you have a question that you hadn't had a chance to ask, definitely go ahead and feel free to put it in the messages, and I will go ahead and try to answer it for you. The next question I've been getting, and again, like the question about when to start taking hormone replacement therapy, I've been getting a ton of questions recently about women who are in maybe their early 40s, who have been breastfeeding and having irregular periods, and they're having a hard time sorting out whether their periods are irregular because of breastfeeding, hormone, or whether they're irregular because of perimenopause, or whether perhaps they're irregular because of something else. And so I thought it would be good to kind of, I think more and more women are having kids in their 40s, and if you're having kids in your 40s and breastfeeding, this is something that can come up quite frequently, and I do see it in my office with my patients as well. So I think it's worth answering because you all have been asking about it. So one of the tricky things about breastfeeding is that breastfeeding hormones really suppress your reproductive hormones. So um, especially early on when you're breastfeeding frequently and around the clock, um, breastfeeding hormones will often suppress ovulation. Not a good form of birth control because you don't necessarily know when you're going to ovulate the first time leading to a period. So, definitely use other forms of contraception if you don't want to become pregnant. But one of the things that can happen even as women get further on, and there is a lot of like your mileage really varies with this. And I often talk about these two best friends that were my patients. They had babies at the same time. And they both had Hashimoto's. And so I used to see them frequently around their pregnancies. And one of them, and they both breastfed, and one of them got her period back at like 4 or 5 months postpartum, even though she was breastfeeding around the clock. And one of them didn't get her period back until she had completely weaned, and then like 2 or 3 months after that. And both of those things are completely normal. It The variability in period regularity during breastfeeding and immediately afterwards is there's tons of variability. And so and so that is normal. Both of those things are normal, and everything in between is normal. So the question is when do you start becoming concerned that your symptoms might be perimenopause? And I think that and do you need to be concerned that your symptoms are perimenopause? I think as long as you're actually still breastfeeding, you if you're not having regular periods, you don't need to be particularly worried. Like I said, that's well within the spectrum of normal. Um, when it becomes more important is when after you've actually fully weaned. And so sometimes people will even be like, well, I'm just comfort nursing morning and night. Most people will get their period back at that point, but many women still won't. And so I think once you've fully weaned, that's when you want to look for your period to come back. And I usually say if you haven't had your period, or if you haven't gotten a period by the time you're have weaned, by the time you're 3 months post fully weaning, that would be when we would want to look into, is there something causing your missing periods, including, this would be in this case sort of an early menopause situation, or is there something else causing your missing periods after weaning? And that's a place where a trip to your gynecologist would be worthwhile. They can do blood work to um, look and see if there's another cause. Hypothyroidism, an overactive thyroid and an underactive thyroid can cause this. There's a number of different other hormonal changes that can cause somebody not to get their period back after they've weaned. But in general, I would say, and once you've fully weaned and it's been 3 months, that's when you would want to talk to your doctor if you haven't gotten a period back. As far as period regularity goes, of course, it's going to take a little longer to see that. By about 6 months post weaning, we would like to see that you're having a period every single month. And if you're not and you're under the age of 45, we should do a workup for that. It very well could be perimenopause at that point in life, but we would still want to be sure that there wasn't some other cause that we would want to treat. If you're over 45, then, irregular periods are most commonly caused by perimenopause in that age range. The other kind of confusing thing in this situation for many people is that um, when your hormones are sort of re-regulating after weaning, you can get some symptoms that can feel a little perimenopausal, some mood changes, sometimes even hot flushes. And so I think, giving it a little time to see if those things settle out, assuming that they're not interfering with your day-to-day functioning, is totally reasonable. Um, yeah. So I hope that was helpful. Um, the last question I was going to get to today, but certainly feel free to pop a question in the chat if you have one. But the last question I was going to get to today was a question about so we I wrote a piece a while back about Hashimoto's and COVID and some new data around that. And I had a question about symptoms of Hashimoto's that sort of flare, and that those flares seem to be COVID related. So the question writer asked, you know, that they have Hashimoto's and that one of the symptoms that they've had with Hashimoto's is hives, unexplained, or what we call it idiopathic urticaria. That basically means hives you have that we don't know what they are, can be a symptom of Hashimoto's. And for some patients, they're a sign that their thyroid levels maybe are a little bit. Um, and so this patient noticed, or this question writer noticed, that her hives would flare after she got a COVID vaccine, um, even if her thyroid levels were fairly normal. And she wanted to kind of understand why that would happen. Um, there's not as you can imagine, there's not a lot of data on this. This isn't an issue that a huge number of people are reporting. Um, but what I would say is hives can be a sign of the immune system reacting in a little bit of an unusual way. And of course, COVID vaccines are purposely triggering our immune system to respond. And so her immune system is just responding in such a way that she's getting a little bit more of a histamine reaction, particularly in the skin. And that as a result, she's experiencing hives. Um, and so it's not so much that the COVID vaccine in this case is affecting her thyroid function. It's that these hives that she gets with the COVID vaccine are probably different than the hives that are her symptom of her Hashimoto's. So I think we will wrap it up there today. Thank you to everyone who joined me today for this chat, for this Ask Me Anything. Um, it is the last Ask Me Anything of 2025. I think the next couple weeks we're all going to be fairly busy with travel and celebrations. But I will be back in the new year. We have some exciting things planned for the new year, and I'll be telling you more about that um, in a post at the very end of December. Um, my next live will be an Ask Me Anything. It will be in early January. So please send me your questions. If you have questions that you'd like to see me answer here, you can DM me through both Instagram, where I am at Jillian M. Goddard, or here on Substack. You can also put your questions in the Hot Flash chat, which you can find on Substack. And you can always email me if you'd like to send me a question, particularly if you want to send it anonymously. And my email is Jillian at thesavvypatient.com. So many different ways to get in touch with me if you have questions or anything that topics you would like me to address. Please don't hesitate to reach out. I'm very excited about my guest. So not my next live, but the live after that. I will be having Marissa Renee Lee as my guest. She's the author of Grief is Love, and she has a book coming out in a few months as well. That book and what we will be talking about in that conversation will be a little bit about the intersection of perimenopause and menopause and chronic illness. And that is a topic that Marissa's been thinking about and writing about recently. And I think it'll be a really fantastic conversation. That will be mid month, and I'll be sending out information about that a little closer to the event. In the meantime, happy holidays to everyone. And thanks again for joining me.